I'll be talking on the screening diagnosis and the molecular markers in lung cancer. This is just a quick disclosure. So the content of my talk will briefly talk about introduction of the workflow that we have at our center, which is a multidisciplinary hospital, and touch briefly on histopathology, cytology, a bit of a classification. We'll spend a bit of time talking about molecular testing and panel testing, touch briefly on PD-L1 testing, a little bit about emerging markers. I think some of the earlier lectures in the first group of lectures have already touched on some of these newer emerging markers, and then hopefully finish with a summary. So this is my hospital. I think some of you may have the pleasure of visiting. We were lucky to move into this 13-story building. We are on the 10th story of this building, and we do have quite a good view. Over here, we have the cancer center at the top left. We have a little museum with our Boyer block, relics from the post-colonial days. And then we have a heart center, and then our diagnostic pathology tower on the bottom right. So we move in here. I think it's an important slide that I always emphasize is that the lung cancer management today is now a multidisciplinary team approach. We have surgeons, we have respiratory physicians, we have intervention radiologists working with oncologists, palliative care doctors, as well as pathologists, ensuring that the entire stream of diagnosis to terminal care is taken care of for the cancer patients. So just important note that, even as pathologists, which I lead a team of, we work closely with all the different clinicians to ensure that there is adequate tissue, and we manage that tissue properly so that the results are given back to the clinicians accordingly. So over here in our center, respiratory physicians, radiologists, and thoracic surgeons all do the biopsies from different methods. And we have worked with them with different workflows on how to handle and maximize the tissue for diagnostics. We've also worked closely with the oncologists to ensure that any algorithm testing that we do, and I'll show you some examples later, has been worked out over time. And we all agree on a particular workflow before we launch that. So for histocytology, I think one of the important areas in lung cancer management will be the on-site cytology assessment. And this has been a real improvement, especially when core biopsies are done either by radiologists or the respiratory physicians. So now we have a on-site assessment. A cytotechnologist is present in the intervention radiology suites as well as the bronchoscopic suites, where smears are done to ensure that there is enough tissue or tumor cells present before we process them further. So some quick examples here of a CT guided or a FNA of the neck. And then in cytology, of course, we can make a very quick diagnosis using PEP and DQ stains on small cell, non-small cell. And then here on the bottom right, you can see some keratinization, which is for squamous cell carcinoma. So we provide that all now across the different sites in the hospital. And this is very helpful to ensure that there is enough material and sometimes to triage the material if there is questions, or for example, for lymphomas as well. For pro-effusions, we have a workflow that in all malignant or query-malignant diagnosis from the clinicians, a cell block preparation is done, and I can show you some examples of why that is very useful for downstream testing. Another thing that we did early on in tissue processing was that in previous times, all the tissues would be put into a single block. But now what we have done is that for all the tissue biopsies coming from the lung cancer patients or query cancer diagnosis, we've split them up so that there's one block for molecular testing and another block for IHC, and that will ensure that it is not exhausted for one or the other test alone. Tissue processing is very important. We run a big lab. We have 9 different tissue processors, 3 different brands. And I think it's important for the pathologists to understand that the different processing protocols and the time in the fixation, as well as the temperature of the formalin, will affect the quality of the DNA and RNA. We spent about 2 years optimizing this to ensure that our DNA quality was 400 base pairs. And we have recently finalized a RNA protocol to ensure that there's at least 200 base pairs of RNA for analysis, especially with the fusions panels coming on board, right? For Profluid, we try to make sure that adequate amount is sent to the cytology lab as soon as possible. We process them for smears, as I mentioned earlier. In any case of query malignant diagnosis, we do a preparation for the cell block to ensure there is material for further testing. Move quickly through to classification, which will not be comprehensive. So I think when I first started training, which is about 20 years ago, we were only interested in small cell versus non-small. And you can see from the earlier set of lectures in terms of therapy, that now has become much more important to differentiate. And we're looking at different treatments for small cell, for adeno-CA, as well for squamous cell carcinoma. A quick example here of some histology H&E images. On the top left, you can see the keratin curls. This is squamous cell carcinoma. And you can see a cribriform pattern, and then a large pattern here of very large nucleoli in a large cell neuroendocrine carcinoma. Over here, these are the standard patterns we see in adenocarcinomas with the papillary, micropapillary acinar, lipidic type, as well as the solid type. Other subtypes are important, including signet ring and mucinous, some of which may be associated with certain molecular phenotypes. So this is the new WHO, where they have a long list. I won't go through this in detail, but just key to point you out here is in the diagnosis here of small biopsies. Do take note that in addition to making a diagnosis of adenocarcinoma, which we may sometimes need additional stains, which I will go through later, we also try to indicate the patterns that are present, including, as I mentioned, lipidic, acinar, papillary, solid, or micropapillary. When there are other subtypes that are present, including squamous, we do make a mention that there may be other types, and these often may be supported by immunostains. So here, for other types of non-adenocarcinoma, you can see for small cell is quite straightforward, but for some of the other rarer types which are diagnosed usually in the resections or by exclusion, we do make note that we just make it as a non-small cell or non-squamous cell carcinoma with neuroendocrine morphology. Some immunostains which are useful for us to make the diagnosis include TTF1 and nepsin-A for adenocarcinoma, and P40, which is a nice stain for squamous cell carcinoma. So a quick example here of a cell block. You can see we do a TTF1, very nice nuclear staining on the right for us to help us to confirm a diagnosis of adenocarcinoma. P40 on the left top here, you can see very nice nuclear staining, and then nepsin, occasionally we use it to identify TTF1 negative adenocarcinomas. So of the different specimen types, including tissue that I've shown, we also have cell block cytology specimens, and we also sometimes have fluid and CSF effusions. So I think whenever you are able to do a cell block, we prefer that because we'll come to the point of tumor content, right? So here, this is a whole piece of biopsy, and you can see if the tumor was only in the gray portion and the rest of the orange portion was non-tumor tissue, if you took the whole piece, there's only a small area of the tumor. But if you're able to dissect out this area on the left, is in the small box, we can enrich for the amount of tumor, and that could rise to 50%, and that will help because with molecular testing, the sensitivity of different assays, including next generation sequencing, are always augmented with higher tumor content. Move on now to molecular testing, where I'll spend a bit of time going through the panels that we've developed. So it's important to note that for molecular testing, there's prognostic as well as predictive markers. Prognostic markers help us to determine the cause of the disease regardless of treatment, whereas in predictive testing, this is often associated with response or a lack of response. As mentioned earlier by the first speaker, some are positive and some are negative predictive markers. A quick scan here of the NCCN. Now you can see the EGFR testing, ALK-ROS, BRAF testing, as well as PD-1 are all in the category 1 area. And of course, there are more and more markers being developed, and you heard earlier about TMB as well. So here is a quick run for non-squamous adenocarcinomas. You can see EGFR has been a mainstay, but all these markers now have come into a clinical practice with actionable targets. ALK, ROS, BRAF, PD-1, of course. And then, of course, mentioned earlier lecture, we're talking about second generation versus third generation TKIs in the T790 space. There are also more and more markers coming up, MET, especially in the MET exon 14. I'll mention a bit about that later, as well as MET amplification, both in terms of primary diagnosis as well as resistance to EGFR TKI. HER2 now, there are targets available that can hit this, drug targets available, RET, and then, of course, NTRK fusions for NTRK 1, 2, 3, which, of course, is another area which I'll touch on a little bit later. So this was our older algorithm for non-small cell lung cancer first-time diagnosis. We would do EGFR either by COBAS or by Sanger sequencing, depending on the amount of tumor present. And then we had a FISH panel which included ALK, ROS, RET, breaker parts to determine the fusions, and CMET FISH, which would look at CMET amplification, and we added a PD-L1 IHC. I say this until April last year because in April last year we did launch our own customized NGS panel called the Somatic Solid Tumor Panel. And we covered 12 genes, including EGFR, KRAS, BRAF, MET exon 14 skipping using DNA, PIK3, TP53, PTEN, as well as HER2 mutations. We have PD-L1, IAH, GTPS, and I'll cover a little bit about that. And then, of course, we continued our FISH, which included elk cross rats, as well as c-MET for amplification. So we have published one paper here in the team in our center showing the cost effectiveness. There was an improvement of getting more targeted mutations detected using a consecutive a first-line approach of NGS versus sequential testing gene by gene. And we showed that this was cost-effective and able to turn around in about 2 weeks. We move on to a bit of PD-L1 testing now. So with PD-L1, I think everyone is very familiar. I think earlier lectures have already touched on the importance of PD-L1 in terms of the stratifying for primary monotherapy versus chemo-IO therapies. So I think you're all aware there is an atlas, and I think the first speaker has alluded to this blueprint study where for tumor proportion score, the first 3 antibodies do show a very good high concordance, except for the SP142. Right. So PD-L1 scoring for IO treatment, there's 2 main methods, combined positive score looking at immune cells. There are other methods that look at area, including immune cell content IC, and then tumor proportion score, which is mostly used in the lung space. So I'm glad to say if you're a lung pathologist, you don't have to worry about the combined positive score, which is much more complicated. You just have to worry about the tumor proportion score, which is the number of tumor cells staining with any amount of membrane positivity divided by the total number of viable tumor cells in the biopsy or the resection and represented as a percentage. So some quick examples here on PD-L1. You will see here a nice tissue biopsy, a transbronchial with some of the salivary type glands present, and a very strong PD-L1 staining, which is almost diffusely positive, more than 90%. This is an example of a cell block. You can see here the tumor cells and the H&E. The TGF1 stain here shows some of the nuclear staining. And it's much harder, I find, on the PD-L1 that we use the SP263 on to look for these cells that are positive. So in cell blocks, we do, and there are now guidelines as well as many papers talking about concordance of this, but I do have to admit that in my own practice, cell blocks is much harder than biopsies to score for PD-L1. It's important to know the clone we're using. We have both these clones. In fact, we have a few additional clones now, especially in different cancer spaces, especially breast cancer. And we use primarily SP263 for tumor proportion score in lung cancer. Important to note that internal as well, positive and negative controls are definitely required, trained pathologists, and then knowing how to report this, and of course, ensuring that the lab also follows an external quality assurance program, and when there are difficult cases, to have internal consultations and review of results. We move on quickly to emerging markers, and some of these I think have been mentioned earlier. So the first of all, I think you've seen tumor mutation burden. There are multiple panels, different methods of analyzing this. All of these will require a next generation sequencing panel of fairly large size. You're talking about 400 to 500 genes, and the panel would have a content beyond 1 megabases. So as mentioned earlier, I won't go into much details. There are several different panels available and different methods of scoring this. There hasn't been a very good consensus and it's not fully validated, but this has been provided by some of the commercial companies as well as the panels that the labs can run. Next, we move on to MET exon 14, which is an interesting new target now. So what happens in MET exon 14 is the exon 14 is skipped during transcription, and this can occur with mutations at either intronic sites or sometimes even a large deletion. The importance of this is that this leads to constitutional activation of the MET gene, which is now targetable by some new drugs. Do take note that DNA-based as well as RNA-based assays to detect MET exon 14 has slight differences. You can see with DNA-based, we are able to detect DNA variants, including the Y1003 point mutations, which may not be detected by the RNA assay. However, there is a lower rate of detection because not all of the changes that lead to MET exon 14 are captured on the DNA pool. And based on the limited primer design, large deletions and sometimes involving primer binding sites may be missed on the DNA assay. DNA assay, however, is much more resistant, I mentioned earlier, with FFPE tissue a bit of pre-analytical work must be done to ensure that you have good RNA. So RNA on this, on the other hand, will detect the MET exon 14 irregardless of the mutations they are, and therefore it is a little bit more sensitive. And in terms of coverage, it is independent of the underlying genomic event. However, RNA is more prone to degradation, and you would need to ensure that the RNA is of good quality. If not, you would lose a lot of specimens if there was a failure of the assay on the RNA basis. Another one here, which will be the CMET. We have a CMET probe, which is in red, and the centromere, which is in green. And you can see on the left side here, there's many more red probes present in the cell nucleus compared to the green probes, and this is a case of MET amplification. And over here, where there is increase in both the red and green signals, this is a pattern of polysomy. So there are now emerging data that may suggest that high MET amplification beyond 10, they may be susceptible to some form of targeted action as well. We move on to the other gene that is of very great interest to some of us in the targeted space in terms of molecular diagnostics, and that is the NTRK fusions. So these are the list of NTRK fusions. They occur across many different tumor types. And in lung cancer, there are several that mostly involve NTRK1 that are shown to be positive. These are targetable. The disadvantage is that sometimes there are new gene fusions, and therefore the assay will need to incorporate ability to detect novel fusions. And the other thing is these fusions do occur very rarely, and you're talking about less than 5%, maybe in the 1 to 2% space. And therefore, there's an issue of cost effectiveness in terms of screening for this. NTRK fusions, the breakpoints are scattered, and the difficulty would be that a lot of the NTRK genes contain large intronic regions with repeat sequences, which are very difficult to design primers for, impeding DNA-based sequencing approaches. These are several different methods that you can use, including real-time PCR, FISH, NGS, as well as RNA sequencing. So the different methods, including immunohistochemistry. So there are many different methods, and there are benefits and pros and cons to all these methods. I think with next generation sequencing, you're able to detect novel fusion partners, and you can look at multiple sites and multiple genes at the same time. And most of the trials do use NGS in terms of its NTRK testing. Turnaround time and the complexity of tests is a bit more, as well as cost. And the sensitivity and specificity of the NGS assays vary widely depending on whether you use DNA or RNA. FISH is possible. You would need to have the probes for all of them. Requires fluorescent microscopy, and the target sequence must be known. And so the difficulty is some of the novel fusions may be missed. Real-time PCR assays are highly sensitive and specific, and they are able to detect very sensitively and inexpensive. However, the target sequences must be known, and therefore novel fusions may not be detected. Immunohistochemistry is probably the most widespread. It's quick turnaround, it's inexpensive, and you are able to do it across different labs. The difficulty, of course, is that it detects both the fusion and the wild type, and scoring algorithms are not yet standardized. In our own hands, we've seen that for NTRK1 and 2, the performance of the fusion assay versus the immunohistochemistry is pretty good. However, for NTRK3, there's a bit of variation in terms of the scoring on immunohistochemistry. So we move on now to what we've done. This is a panel that we only launched in April 2019. And even now, we are beginning to think that we will need to add to this and include a portion which has an RNA fusion detection portion, including the NTRKs, MET exon 14, and other new fusions, including NRG1. There are different fusion assays available in the market, as well as real-time PCR assays that detect multiple genes as well. Of course, both Archer, Illumina, and Thermo Fisher have got commercially available panels that can be validated or verified in-house.
Dr. Tim?
To quickly move on to the summary now.
Dr. Tim?
I think with molecular testing, one thing that's very important is in terms of the patient and the cost. So I think turnaround time and accessibility are very important. Cost as well is very important. The logistics, having the pathologist or the molecular pathologist, and the funders, including government and insurance payouts, are extremely important. In our own experience, and our recommendation is that point of diagnosis, broad panel testing seems the most sensible and cost-effective in terms of deciding the treatment. And then moving on, as you have seen in the earlier lecture, in terms of therapy and the ability to even maybe provide cure at some of the EGFR mutant lung cancers, The question, of course, is focusing on single gene or smaller panels to look at treatment monitoring as well as resistance when these occur, for example, with T790M or with osimertinib, C797S, and see MET amplification in other TKIs. Relapse, of course, and then to again run a broader discovery panel, including whole exome sequencing at relapse to see whether there are new actionable targets that can be found. So in summary, I think we are in a point of care where multiple disciplines are required, and clinicians do work with radiologists, pathologists, oncologists to develop these algorithms and ensure there's adequate material for diagnosis. One thing that we do note is that molecular testing algorithms are very important, and there's a comment later on, and this is to provide really the diagnostic opportunity for all our patients going forward, regardless of ability to drugs as well as payment. So I think this is a nice quote I took from a paper by someone from MSK, Gregory Riley. Biomarker testing needs to be customized at each institution, and there is no single answer for all the institutions. And I like that very much because I think that's real, and therefore there is no right and wrong, but really to develop an algorithm that makes sense wherever you are. And that's the most important thing that all of us should aim towards. I'd like to end with a picture I took. This was in the Cherrapunji area, the double living root bridge that we went in Meghalaya. And there was a trip several years ago to Shillong when my wife was invited to give a talk. Thank you very much.